Um, okay, so the chief complaint is, I don't know, the chief complaint is unresponsiveness since the past 30 minutes.
Ooh.
Yeah.
Wow, what a start, Nikita, as always. So, all right, let's think about this. So the patient is unresponsive for 30 minutes. I think when you see that complaint, it's hard. The immediate thing that I would do is just literally go for pulses. So I just want to make sure this person is having pulses, get a set of vitals, just to kind of determine how acute this patient is unresponsive. If they're in an arrest of some sort that you need to call it cold blue, or if you're in a hospital, do a rapid response, or if you're an outpatient, call an ambulance. So again, determine the severity of it. Because, the whole gamut is like someone who has lost the pulse to someone who's just severely altered. And you want to kind of get a sense within those few minutes where you are. So pulses, vital signs are the most helpful. And the other thing is just, you want to make sure that if the patient is somnolent and altered, they're protecting their airway. So I'm kind of like in that acute, just like determine if this patient is stable or not before I do any diagnosis. I was going to call you RG, Jack, and you're just as amazing. Jack, what are your thoughts?
I honestly, I think your approach is absolutely phenomenal. I really have nothing to add to that. I think, we will hopefully get more clarity as things go forward. But I think that approach to just sort of understanding the spectrum of the pathology that we're dealing with is as good as it gets. So Nikita, I will kick it back to you to give us a little bit more. And I also say that I actually appreciated immensely the thoughtfulness of how to frame the chief concern. It is a demonstrative of how much I know you care about presenting cases in a way that are going to facilitate a good discussion. And Charmine's response there is emblematic of how you set up the situation for that to be a really rich discussion. So thank you.
Yeah, no problem. Thank you so much for your kind words. I mean, to be honest, the first time when I did see this patient, it took me a second to really place this person at what symptom they are presenting with. So honestly, the confusion that I had on my face today was the same confusion I had a few days ago when I saw that patient. So yeah, I'll give more history regarding this patient. She's a 56-year-old female who has been unresponsive for 30 minutes. She was found by her husband in her home, and he tried waking her up and she wouldn't respond. So a little backstory regarding this patient. 1 week prior to this episode of unresponsiveness, she had severe chest pain, and for which she was taken to the hospital, and the ER, they diagnosed her to have an inferior wall MI. So this inferior wall MI, there was an angiogram was done. And in that angiogram, they found out that her right coronary artery had complete stenosis. Her left circumflex artery had 70% stenosis. And also her left coronary artery had 50% stenosis, for which they ended up doing a single stenting of the right coronary artery. After which the patient was discharged with normal vitals and the usual workup for a post-angioplasty patient, being clopidogrel, aspirin, and all the other medications. But previous to this acute incident, 3 months ago, she also had bilateral lower limb swelling, which started after she was walking around her front yard and she was hurt by a stone, and it caused a unilateral right leg swelling. And then even her left leg started swelling up. for which at that point of time, antibiotics were given for a week, after which the redness decreased, but the swelling did not. And she ended up going to the clinic again, and she was given a second dose of antibiotics, after which the swelling did not decrease again because they were suspecting cellulitis. So yeah, this is the background of the patients in the past 3 months.
Amazing. Thank you so much for this, Nikita. I think the plot only thickens here. Just to elevate a really important question in the chat that just came up from Pranati. I apologize if I'm mispronouncing your name there. Actually, would love, Pranati, are you in a place to unmute and introduce yourself to everybody and also ask your question out loud?
Yes. Hi, everyone. My name is Pranati. This is the third case that I've come to. I'm a first-year med student, so I'm just trying to follow along with the basics here. And I was wondering if someone could explain what an inferior wall MI is and what the angiogram findings mean.
Yes, absolutely. Pranati, this is a phenomenal question. I'm so glad that you're asking and so thrilled that you're here with us for another case at VMR this morning. Nikita, I imagine that in taking care of this patient, you had an opportunity to learn some about the sort of coronary angiography. You're welcome to answer the question, or I'm happy to try as well.
No, do explain yourself, Jack. I'm happy to present the case.
All right. So just to sort of situate us here, I'm going to turn the camera down a little bit just to point to my chest here. So if we could imagine the heart sitting in our chest like this, right, sort of comes down and sort of sits this way. My left ventricle is over here, and my right ventricle is going to be behind and a little bit below my left ventricle. When we talk about the inferior wall, we're talking about sort of this portion of the heart here, which is where the right ventricle sits. The inferior wall is supplied by the right coronary artery, which comes off of the aorta. And so, Pranati, to answer the question, if we have an inferior wall MI, it means that heart muscle in the inferior portion of the right ventricle, which sort of sits down in this part of our chest, is starting to infarct because there is an occlusion of the right coronary artery, which is one of the main arteries that comes off of the aorta and supplies blood to the heart. And so when she had chest pain, I suspect that they had enough suspicion that she was having a heart attack that they took her to get basically dye injected into her coronary arteries. The cardiologist, she'll feed the interventional cardiologist. She may feed a catheter through the artery of the patient's thigh artery up into the aorta and then into the heart, and then inject dye into those coronary arteries. And when there's a blockage in one of the coronary arteries, you'll see that the dye does not go forward, or if it does, the vessel itself gets very, very thin. So complete stenosis of the RCA means that right coronary artery that supplies the right ventricle of the heart was completely shut off. The partial stenosis of the left coronary artery means that was narrow, but not so narrow that blood couldn't pass through. So it seems as though that the patient had a myocardial infarction or a heart attack because that right coronary artery was blocked off. And then what the interventional cardiologist will do is they'll open up that vessel with a stent to ideally restore blood flow to that part of the ventricle.
Thank you so much for the explanation. I really appreciate it. And sorry if that was like a simple question. I just didn't know what it was because I haven't learned about it yet.
No, it is such a great question. It would probably benefit more from drawings and pictures that I can't pull up right now, but I will see if we can find a way to hopefully expand on that more. But in terms of sort of how this fits into the case now, I will say briefly, it is an interesting sequence of events where we have sort of refractory lower extremity swelling, followed by a new myocardial infarction, and now this episode of unresponsiveness. And what I'm trying to do is to say, are we going to call this a post-MI complication, or is this a part of underlying disease process that has been brewing in the background that led to progressive lower extremity swelling, a myocardial infarction, and now this unresponsiveness? The former, right, a post-MI complication feels much more common to me than some sort of sinister brewing disease, because these complications can happen. And so briefly, right, how can we connect a recent heart attack and stenting to changes in someone's mentation or responsiveness? Well, one end of the spectrum that Charmaine took us through is that we could have sort of cardiovascular compromise that's leading to inadequate perfusion of the brain in the post-MI phase. That could be something, for example, like a valvular rupture that can happen after an MI. We can have a ventricular free wall rupture that happens after an MI, or you can get in the post-MI phase what's called a post-MI pericarditis, where you end up getting inflammation that causes a pericardial effusion, and that could also lead to unresponsiveness. These complications, though, are much less common now than they were years ago, because we've gotten so much better at myocardial reperfusion. So one way of saying are we dealing with a direct myocardial process that's leading to unresponsiveness? And that would be via something like shock or circulatory collapse, which would be the sort of the code or pericode end of the spectrum that Charmaine mentioned. There's also a way that the heart could cause a problem in the brain. And one of those things would be, for example, if she happened to develop an embolism that sent a clot to the brain, we would expect that to have not only decreased responsiveness, but also motor and sensory findings. But you can sometimes have strategic strokes in certain areas of the brain that cause only changes in mentation without things like unilateral weakness. So that's another hypothesis to explore. The last is that we started her on blood thinners, and we know that dual antiplatelet therapy increases the risk for intracerebral hemorrhage. And so if this is somebody who potentially we could be dealing with a brain bleed, that could be a complication here. And then there's the other hypothesis of, was there something brewing the whole time, sort of a low-lying disease that impacted potentially the kidneys, the heart, or the liver, given the lower extremity swelling, led to increased coagulability and the MI that then is manifesting with CNS findings. That would be an esoteric and a rare diagnosis. So I'm going to hold on talking about that more. But I think what we need to do is really focus on the post-MI complications first, which again, thinking about issues with the myocardium, the valves, the pericardium, or strokes and bleeds to the brain. And once we rule that out, then we can go more into the world of the potentially more esoteric diagnoses. Charmaine, what would you add there?
Oh, absolutely. Love that, Jack. And I think the only other thing that I would add is just arrhythmias. And I think Chad mentioned that as well. And just instant thrombosis, if she, for whatever reason, wasn't taking her medications. But that was absolutely brilliant. Nikita, mic back to you.
Yeah, that was a fantastic discussion. In terms of past medical history, she is a known diabetic since the past 20 years, and she's been on 500 milligrams of metformin and 2 milligrams of glimepiride. She's also a known hypertensive, and she's on amlodipine 5 mg. In terms of other admissions previously, she had an episode of anaphylactic shock because of honeybee bite that happened 5 years ago. A year ago, she was treated for diabetic foot. Family history, there's a family history of diabetes and hypertension. She doesn't have any health-related behaviors. And yeah, that's it. I'll go over the vitals right now. Her temperature at the time of admission was 36 degrees Celsius. I think in Fahrenheit it might be around 37, 38. I'm not really sure. Heart rate was 96 beats per minute. Her BP at the time of admission was 100/80. Her respiratory rate was 25. Her SpO2 was 92. On examination, her general appearance, she was not oriented to time, place, and person. In head-to-toe examination, There was bilateral lower limb swelling, and her face appeared puffy too. In terms of her other systemic examination, couldn't recognize anything significant. There were no crackles present. Abdomen was fine. Neuro, she was unresponsive, that's all. But apart from that, her reflexes and everything else was normal. And her tone was normal. I can go over the labs if required, or we can discuss with just the vitals and the past medical history.
If you want to just give us labs because just the sake of time, Nikita, that would be great.
Yep, for sure. Her hemoglobin was 14.3. Her platelet count was 3.57 lakhs, which is considered normal. Her total WBC count was 13,620 cells. Potassium was 3.8. Chloride was 101. Sodium was 135. Her random blood sugar at the time of admission was 35. I think we can stop there for now.
All right. Thanks, Nikita. Just to make sure I heard that correctly, the glucose was 35?
Yep, 35.
Lovely. And just to orient myself a little bit, in terms of her unresponsiveness, was it like she wouldn't wake up to a sternal rub? Was she just like but awake, looking around, but not communicative? Can you kind of describe what you saw for us?
Yeah, so this is the reason why I was confused, because I wasn't very sure whether I could call it unresponsiveness, because she would look around, but it was but she was awake, but she was just looking around and was not verbally responsive. So I think that's the reason why I use the term unresponsive, just because I wasn't very sure at what degree could I like call her unresponsive, you know?
Yeah, no, it's totally tricky, and she's being unresponsive to you, but that description is like so helpful. Because in my mind, like if somebody's like, you know, that tells me like, you know, at least like she's protecting her airways, the SAT as well, versus like if she's like, you can't even wake her up with the sternal rub, then I'm like, okay, I need to worry a little bit more about the airway. So thank you so much. That was super helpful. So in terms of just the vitals and the exam, so the vitals is a bit reassuring, right? She's like sounding okay. Her blood pressure for someone who has history of hypertensive and amyloidopenia, I can imagine might be a little bit low for her. But again, this is not, as we were talking about it earlier, like this is not someone who's like in cardiac arrest. Vitals are a little stable, so we have a little bit of time. She's looking around, but she's like severely altered. And with altered mental status, you know, we love our mismnemonic of metabolic, you know, infection, structural toxins. And, you know, the one thing that I always like try to remind myself, and I tell my teams all the time, is like, you know, in a high stakes situation, when you walk in and patients are altered or like non-responsive, the one thing is checking a finger stick glucose. And I have forgotten to do that multiple times. It's so easy to escape our mind, and it's easy to do, and it's very, very good, a very like important thing, because like if someone is like hypoglycemia, can mimic so many things and can make you severely altered. And the good thing is like it's easily reversible. And this patient's glucose is 35, and she has history of like diabetes in the past. She's on metformin, but you know, usually with hypoglycemia, we think about whether it's like insulin mediated or non-insulin mediated. So the question is, how is this patient so hypoglycemic? Is it like medication related that a lot of the time can happen? Usually it's like in the setting of like, oh, taking too much insulin. And you know, usually in outpatient setting, like, those are the people who actually like tend to be on like long-acting insulin injection. I personally, and the other medications that cause hypoglycemia is like glipizide that you can think about, thinking about your metformin usually is not as much unless like the patient took so much of it, or is there anything else that that has led to that patient having a low glucose? The other thing to think about, delayed, there's causes of pseudohypoglycemia as well, which like peripheral vasoconstriction. So it's so clamped down that you're just like not getting an accurate reading, and delayed sampling process that I don't think that's how that is indicative of that. We don't have a creatinine, and that's one is like important to know, like if she has a severe AKI and is setting up metformin, any medications that can induce hypoglycemia as well. Or like, if patient is like severely septic, you can have increased consumption as well. And there's like other medications that can do it. But 35 is really, really low. So I would just like give this patient lots of glucose and put them on a drip and see if, again, the altered mental status reverses or not. Because if it does, then it's like hypoglycemia, give them sugar, they're doing better. Or is there something else that we need to worry about? Jack, what are your thoughts?
I think that was flawless. I really have nothing to add here. I think the challenge is determining, is the glucose related to, or is the glucose the cause of her altered mental status? And if it gets better, then that gives us the answer. Or are we going to have to dig for an alternative cause? And maybe the hypoglycemia is a bystander to whatever the primary disease process is.
Yeah, so I've got 2 more labs. Her serum urea is 35. Her creatinine is 1.4. I pulled up reports from 3 months ago, and her urea at that point was 35 again, but her creatinine was 1.2. An ECG was done, and an EKG was done, and the EKG showed no new changes. It was just the old changes from a week before the inferior MI. And her chest X-ray was clear.
All right. Nikita, how is after this information, is there more data to come before a final diagnosis, or is this all that we have?
This is all that we have.
All right.
Super simple.
I love it. So, I think then, it seems as though we sort of are dealing with sort of minimal responsiveness, or as Charmaine said, acute encephalopathy, leukocytosis, hypoglycemia, maybe a slight AKI, and a clear chest X-ray with no EKG changes. And I think I will just build off of what Charmaine was saying in terms of the hypoglycemia discussion. I think there in our insulin-mediated causes of hypoglycemia, there are oftentimes endogenous or exogenous insulin that somehow gets on board, whether it's an exogenous source like Charmaine mentioned, someone who's on long-acting insulin, or an endogenous cause, which can come from something, for example, like an insulinoma. But far more common is that we're dealing with a non-insulin mediated process. And something that I learned that has been helpful is to ask myself, where does hypoglycemia fall on the patient's problem list? And if there's many other things going on in addition to their hypoglycemia, it's more than likely that this is a non-insulin mediated cause of hypoglycemia. For example, sepsis or intoxication or something else that is or for example, decompensated liver disease, right? There is some sort of other disease process of which hypoglycemia is a complication. Whereas when someone's primary problem is only the hypoglycemia, then we're likely dealing with a insulin mediated process, right? If they're just coming in, their blood sugar is 20 and there's nothing else happening, then it's likely in the insulin mediated range. In this case, right, we have this sort of leukocytosis that we have to explore, and it's totally possible that this could be sepsis induced hypoglycemia. This is somebody who it seems like has had multiple illnesses recently, including a recent hospitalization. And so I think I would probably explore, exactly as Yasmin said, the infectious route here. But if that ends up being negative, then we may go and have to look for the insulin-mediated causes, which is going to involve testing with things like a C peptide or things like that. But I completely agree with your thoughts in the chat. Yasmin, rule out the other infectious etiologies. We'll get blood cultures, we'll check urine and urine cultures, we'll get liver enzymes to look for hepatobiliary infections, and we'll really do a thorough hunt for any sort of infection, including the CNS, if we feel like we need to go down that route. And if we've cleared that up, we've evaluated for the non-insulin mediated causes, then we go down into the world of esoteria and look for endogenous or exogenous insulin consumption or insulin production. Charmaine, I know you have to pop off, but anything to add before you have to go?
No, I love that.
Yep. When this patient arrived in the ED and we first did the random blood sugar and was 35. So as you mentioned earlier, because her glucose is really low, it's hypoglycemia, dextrose was given so as to get her back to normal. So in day 2 of her admission, after her hypoglycemia was corrected, the labs were again run, and in order to rule out infection, all her hepatic workup was normal, and her urea creatinine were again the same, and her WBC also improved. The next day it was around 10,000. So after seeing how the case unfolded and the fact that she's been having 3 months of lower limb swelling, and her creatinine has been kind of in the higher range since the past few months, we considered that she might be just having chronic kidney disease, just because she's also on metformin, and metformin is not usually it's not supposed to be given in people with GFR less than 30, and her GFR was less than 30. And also with CKD, because insulin is renally cleared, there's so much insulin that is circulating that causes a state of hypoglycemia. So we are also assuming that her glucosidosis is just because she had a recent admission and an invasive procedure. So this is just a good old chronic kidney disease is what we anticipated out of it. She drastically improved like within a day of admission. So yeah, this is to CKD.
Amazing. Wow. Well, I will say this was an incredibly fascinating case, and it really highlights that, I think for me, it really highlights the value of really sticking to the basics and the fundamentals as we reason through cases, right? Like we could have explored the world of post-MI complications and all these other really challenging things, but ultimately it was the core basics of the evaluation of somebody who was altered or unresponsive, and getting that finger stick glucose as quickly as we can, that ultimately unlocked the answer to this case. It's just a huge relief to hear that she's recovered and is doing much, much better. Charmaine, what thoughts do you have?
I 100% agree. When you see hypoglycemia in someone who's a type 2 diabetic on oral medications, I think kidneys is a good one to think about because, as you mentioned, Nikita. And the other thing I'm curious about, was there ever a lactate drawn?
I don't think so.
Okay, cool. No, the only reason I wonder, because with metformin, especially if you have a low GFR, you're at a higher risk of kind of developing type B lactic acidosis, especially in people who have really bad CKD. And, and it kind of, so it's another clue. Again, it doesn't happen all the time, but something to think about. And the other thing that I was just reflecting as you were talking, because, creatinine of 1.4, it's elevated, but, elevated, but it's not as severe as I would have thought. So it kind of reminds you to just think about the eGFR, think about cystatin, think about the renal clearance. It doesn't always mimic, especially if someone, their body mass, body habitus, a lot of things affects your clearance as well. So it's true CKD, the creatinine alone, as perhaps not always the best marker to think about, because it sounds like she has a lot more severe chronic kidney disease than that I would have thought. So this was fascinating, Nikita. Love the case. Jack, any other thoughts?
I got nothing. That was an absolutely incredible pearl. And I think we have some amazing teaching points to go through now. Leigh, do you want to take us away?
I'll start with the teaching points. So thank you for the case and the discussion. And so we started out by talking about the main symptom of unresponsiveness. And so we were reminded that it's important to at first evaluate the urgency and check the vital signs for that. You can make sure that the airway is secured. And sometimes it's like important to treat the patient before you get the actual diagnosis. Then we discussed inferior wall infarction and how it's the right coronary artery that supplies this area of the heart. And that the angiogram is used not only for like diagnostic purposes to make the stenosis visible, but you can also use it therapeutically by placing a stent with the procedure. And then we also talked about how there could be post-MI complications that can cause unresponsiveness. And it can be either by like having like a perfusion deficit, so that the cardiovascular system is compromised. This can be either by valvular rupture, ventricular wall rupture. You can also have a post-MI pericarditis or an arrhythmia. And then also if, for example, due to an arrhythmia or turbulences in the heart, you can also have embolic strokes that can cause unresponsiveness, or for example, if the patient is on dual platelet therapy, then this is a higher risk of bleeding that can also lead to these symptoms. Then, of course, we mentioned the known missed mnemonic that is helpful when we speak of altered mental status. And Charmaine reminded us how important it is to check the glucose, just because it's a great mimicker, so it can have all sorts of presentations, and it's something that can be easily treated as well. And then continuing with hypoglycemia, we had pseudohypoglycemia. That is something where we have a wrong result of the test due to peripheral vasoconstriction. And then what can be helpful is to separate hypoglycemia into two buckets, to have like insulin-mediated and non-insulin mediated. For the insulin mediated, you can also think of exogenous causes like medication, for example, and endogenous causes that increase insulin. And also a pearl that Jack shared is that it can be a clue for an insulin mediated process if the hypoglycemia is our main symptom in this case. And non-insulin mediated would be, for example, in case of an infection or sepsis where there is more consumption as well. And then finally, we had like shared in this case, we had a person who had chronic kidney disease, and this person was also at a higher risk for hypoglycemia. So in patients with chronic kidney disease, especially if they have diabetes and medications, make sure to check the GFR for the dosing, or if you can give them metformin. And also make sure that if the renal clearance is compromised, then there might be a risk of accumulation and hypoglycemia due to increased insulin. Yeah, thank you everyone for joining.
Yeah, that was absolutely fantastic. Such a brilliant synthesis of the case. And again, really reinforcing these core teaching points that came up from an incredibly fascinating, and again, a case from you, Nikita, that highlights just how the bread and butter stuff is always interesting, and there is so much to learn and unpack from them. I want to give a huge thank you to Shema for scribing. And again, Leah, those were absolutely brilliant teaching points. Thank you so much for taking the time to put them together and relay them in such a thoughtful and well-delivered way. Sharmiz, if you're still there, thank you again for a blast of a case discussion. We hope everybody has a great day, and we will see you next time. Bye, everyone.
Thank you all. Just because I'm a huge nerd, Nikita and I were nerding some more about this case. And just another thing to remember is like her hemoglobin A1C was just a 6.9, and she was on 2 oral medication. So probably, you know, she was like on too many medications plus her worsening CKD, like those two together is probably a double hit for her hypoglycemia. Anyways, Thanks again, all. Have a good one. Bye.
I can add another point. Soon after, during her discharge, they changed the medications from just metformin Glimy to only Glimy. So yeah, it was decreased post discharge.
Amazing. Thank you all. Bye.
Yeah.